Hello and welcome everyone. We are about to begin our deep dive into a clinical anatomy of coronary artery through case study, which is a topic that is fundamental to both anatomy and radiographic interpretation. The purpose of this educational video is to provide a comprehensive demonstration of the anatomy, function, and clinical significance of the coronary arteries. We will explore the main branches, their surface landmark, and their corresponding areas of perfusion. Most importantly, we will integrate this anatomical knowledge with radiographic interpretation skills by analyzing multiple clinical case studies. What is heart? The heart is a muscular pump located in the thoracic cavity, slightly left of the midline. It beats continuously to circulate blood throughout the body, delivering oxygen and nutrients to every organ. To maintain its own function, the heart also needs a dedicated blood supply. This comes from the coronary artery. The heart is a hollow, muscular organ located in the thoracic cavity, functioning as a dual pump for systematic and pulmonary circulation. It has 4 chambers, which is right atrium and right ventricle, who pump thus deoxygenated blood to the lungs via pulmonary artery. Left atrium and left ventricle take action in pump oxygenated blood to the body via the aorta. The heart itself requires a dedicated blood supply delivered by the coronary circulation. Efficient coronary blood flow is essential to maintain the contractile function of the heart. A precise understanding of the coronary anatomy is not just academic, it is absolutely crucial in radiographic practice. The ability to accurately locate a stenosis, narrowing, or an occlusion, which is blockage on a CT scan or an angiogram, relies entirely on knowing where the vessel should be and what normal variation looks like. This foundational anatomical knowledge directly impacts the accuracy of diagnosis and ultimately effective patient care.
So let's begin about the coronary arteries. The coronary arteries are the vessels that supplies oxygenated blood to the heart muscles, which is called myocardium. They arise from the ascending aorta, specifically from the left and right aortic sinuses, just above the aortic valve. Now this is the anatomy of coronary arteries. With the right side, we have right coronary artery, which is RCA, right marginal artery RMA, acute. Then on the left side, we have left coronary artery LCA, left circumflex artery LCX, left marginal artery LMA, obtuse, left anterior descending artery, and diagonal arteries, which is start with left coronary artery, arises from the left aortic sinus of the ascending aorta immediately above the aortic valve. It will passes between the left auricle and the left side of the pulmonary trunks, and it will run in the coronary sulcus. Branches towards the apex and turns toward posterior surface. Left coronary artery is divided into 2 branches, which is left anterior descending artery (LAD) and left circumflex artery (LCX). The lateral branch, which is a diagonal artery, which descends on the anterior surface. It's over here. And the LCX branches follow the coronary sulcus around the left border of the heart to the posterior surface of the heart. So let's move on to the right coronary artery. Right coronary artery originates from the right aortic sinus at the root of aorta. It passes forward to the right, and near its origin, RCA gives off an ascending sinoatrial nodal branch which supplies the SA node. At the posterior aspect of the crux of the heart, RCA gives rise to the anterior ventricular nodal branch which supply the AV node. The dominance of the atrial system is defined by which artery gives rise to the posterior interventricular branch, which descends in the posterior IV groove towards the apex of the heart. Left coronary artery supplies the left atrium. It has the most on the left ventricle. It parts of the right ventricle. Most of the IVS include AV bundle of the connected system. And the SA node is 40% of people. While the right side, RCA supplies the right atrium. It has the most right ventricle, part of the left ventricle of the IV septum, usually the third posterior. And the SA node is 60% of people, and the AV node is 80% of people.
Next is clinical case study. Our group chose article about myocardial infarction in a young man. Next, brief summary of the case. 22-year-old Japanese man presented to emergency department with anterior chest pain that occurred at rest and lasted for 50 minutes. The pain score is 10 out of 10, oppressive and persistent. resistant. Otherwise, no cold sweat, no respiratory fluctuation, and no fever. He also has no history of smoking or drinking alcohol. Then, for past medical history, firstly, he has essential hypertension, which is high blood pressure, that diagnosed at 22 years old and on 80 mg nifedipine, 4 mg doxazosinacylate on a regular basis, and his blood pressure was well controlled. Secondly, he has grade 1 right hydronephrosis, which is swelling of the kidney due to accumulation of urine. For past surgical history, he has left inguinal hernia when he was 5 years old. Moreover, for family history, his older brother, father, and grandfather diagnosed with hypertension and on antihypertensive. Second, no history of malignant disease and familial hypercholesterolemia. For physical examination, he has BMI 25.7 and all his vital signs were normal other than hypertension with blood pressure of 147/87 mm per mercury. Electrocardiogram ECG is one of the diagnoses for myocardial infarction. ECG shows ST elevation in anteroseptal leads V1 until V4 is confirmed, which indicate a complete blockage of the left anterior descending artery. This can lead to the death of heart muscle cells due to lack of oxygen. Reciprocal ST depression in inferior lead help to confirm the diagnosis of an anterior infarction, which relate to the symptoms of anterior chest pain. The second modality is transthoracic echocardiography. It confirms severe hyperkinesis of anteroseptal motion, which contraction of the heart muscle is reduced, causing ability to pump blood ineffectively. Left ventricle ejection fraction (LVEF) was only about 20 to 30%. LVEF is ability of left ventricle to pump oxygenated blood to the body through aorta. The normal range is 50 to 70%. If it's too low, causing sudden cardiac death and all-cause mortality. And other findings were normal. Lastly is CT of the chest, which is normal result. The last way to diagnose myocardial infarction is coronary angiogram (CAG). The left radial artery approach with a 6-French sheath that indicate a blockage in the left anterior descending coronary artery. Based on the imaging finding below, it confirmed that 100% occlusion at segment 6. Segment 6 refers to proximal segment of the left anterior descending artery. Lastly, the treatment is percutaneous coronary intervention (PCI). The stent was inserted to the artery and inflate the balloon to reopen the blockage and increase blood flow.
Clinical relevance and reflection. Have you ever wondered what are the importance of understanding coronary anatomy in radiographic imaging and diagnosis? The importance in radiographic imaging. Number 1. Accurate artery identification. Facilitates precise recognition of coronary arteries, including the left anterior descending, left circumflex, right coronary arteries, and their respective branches. 2. Proper image interpretation. Minimizes diagnostic errors due to normal anatomical variations. Next, the importance in diagnosis. Number 1. For early detection of disease. Number 2. Assessing the severity of disease. How about anatomical knowledge aids in accurate interpretation and patient care? Number 1. Accurate interpretation. Reduces the chances of mistaking the structures of pathology by improving the image reading accuracy from understanding the normal anatomy. Having the strong foundation of anatomy can also reduce the diagnostic errors such as misinterpretations of shadows or positional changes in imaging. By understanding anatomy and knowing where the structures lie will ensure that the images are clear and useful due to the competent use of projections and imaging techniques. Number 2. Patient care. Knowledge in anatomy can avoid injuring the vital structure. Physical examination skills can be enhanced with anatomical knowledge. Anatomical knowledge is essential for the delivery of effective first aid as it facilitates the accurate identification of injury sources and ensures the appropriate administration of medications.